My name is Jason Larsen. I'm CEO of Assurance Healthcare and Counseling Center, joined with my business partners, Dr. Edgerly and Holly Porter.
Hi.
We started Assurance Healthcare and Counseling Center, all three of us together, in January of 2014. We're in central Washington state, so we're on the east side of the mountains. We're not in the big Seattle area, but Yakima, Washington is an area of about 92,000 in Yakima proper, and maybe around 250,000 in the greater rural area. So we're definitely considered rural where we're at, but it's worked well to integrate mental health into our DPC practice from the very beginning. So take it away.
Thanks. Dr. Edgerly is going to start for us to emphasize the why did we do this? Why did we incorporate mental health into our DPC model?
Hi, everybody. Thanks for joining us. Yeah, so as every primary care physician knows, we see out of our plethora of patients a day, people that need mental health counseling, whether it's anxiety or depression or PTSD or whatever. Unfortunately, we don't have the time to spend with them, and we don't have the skills to give them the counseling that they need. So I used to be in a partnership with 3 other physicians, and we even went as far as to develop a panel of mental health counselors that they could see. We would give them this list of, hey, you need to see one of these 6 people. We would place them on an antidepressant, for example. They would come back in a month. They're doing a little bit better maybe on the antidepressant, but none of them would go to a counselor. It was another deductible. It was another copay. It was another visit across town to find one. And it raised a whole bunch of barriers. So when we started Assurance Healthcare and Counseling Center, we just said, why can't we integrate this together? And so then the patient can come into the same office, they can have the same chart, they don't have to re-meet people, no copays, no deductibles. Direct primary care works perfect with that system.
It also really led to, or coincided with our mission of, we wanted to be very person-centered and patient-centered in our approach to the healthcare that we were giving through our DPC. And so I'll give one disclaimer as I start. I'm a licensed mental health counselor, and I practice psychotherapy with a very strong person-centered focus. I'm not a behaviorist. And there are a lot of behavioral health models that are integrated into a multidisciplinary care where we couple medical with counseling. But the advantages and the benefits and the outcomes that we have seen are by implementing a psychotherapy model into our practice, not a behavioral health model. We don't have time to get into all the distinctions between those, but those would probably not translate the same. And the things I'm going to talk about would not necessarily be accurate if you were doing a different kind of therapy model, probably especially a more behavioral health focused model. But let's jump into what are those advantages of incorporating a counseling service into your DPC, not just it's like linked somehow with, this is our referral process, but actually within your own clinic. Like Dr. Edgerly started to mention, the biggest one is access. When you incorporate a counseling service into your model, it increases accessibility by a landslide. Usually, individuals are going to utilize their PCPs to start the referral process of going into counseling. And like Dr. Edgerly said, at best, they might come out with a name or a list of names of who to call in the community. And at worst, they're just told, like, you should just go to do some counseling. And so from there it's a new phone call. It's often actually statistically up to 6 phone calls that an individual has to make before they are establishing service for mental health. And imagine doing that when you're utterly depressed. You've now explained yourself. I mean, at best, maybe you did it 50%, right? You did it 3 times. You're done. Why would we fault them for giving up in that process? It's another receptionist. It's another building to locate. It's another parking lot to figure out, which is so much more difficult in some of your bigger cities, obviously. It's another copay. It's another set of paperwork. Another. And imagine doing that process again multiple times just to be able to get in and get seen. However, when, like our practice, when the therapist is down the hall, they have a name, they have a face, they have an office that immediately becomes familiar, and the patient often is able to even schedule that appointment before they leave the clinic that day if they utilize one of the medical providers to start the counseling process. But if not, if they self-refer, they call the same receptionist, they talk to Kim here at our office, they're going to come to the same waiting room and sit in the same lobby. They're going to know where the bathroom is. They're going to know what the office is going to kind of be like. And there's a familiarity with just even their care team. They connect, people connect that, well, because they connect with some of the other people in the clinic, they also now, it's like vicarious connection to the therapy world. Familiar is comfortable, and it breeds other internal responses for us, like safety and calm and feeling supported. And if we can shift someone to face that direction as they start a counseling journey, they're already looking towards better and being healthier just because of those pieces. So that access piece is a really huge component. Another benefit is we have the potential of slowing the acceleration of illness. Just like as the DPC model has brought accessibility and availability into the medical world, it translates as well into the counseling world. It breeds a much better culture of health and wellness, and it catches things quicker because you can get in. So just as maybe we would want a patient to come in quickly for a UTI so it doesn't become a kidney infection, we want people to come in at first symptoms of major depression, a major depressive disorder, instead of waiting till persistent depressive disorder or dysthymia has set in. 2 weeks versus 2 years, huge difference. Or let's try and catch OCD symptoms before the individual suffers from agoraphobia. Or what if we can help an individual as they had a first episode of mania, when we're trying to treat bipolar 1, and start implementing some DBT techniques so that next subsequent mania cycles or to limit them and limit those negative effects of those. If we look at next benefit of promotes collaboration. Most times, right, when you have a third party, when an individual is seeking services outside, it's a huge process to try and collaborate at all. It's ROIs on both ends. They all have to be signed. They have to be faxed. It's playing a wonderful game of phone tag with a provider. It's staying in on your lunch so that you can actually talk about it. It's getting different stories. It's a complicated burden. Whereas when we're all in-house, we can consult in the door frames of our offices. It's all the way up to having very formal, case consult, let's staff a patient and make sure that we're all on the same page. So that is not only hugely helpful to the provider team, but it's so wonderful for the patient. And it allows collaboration as we see more and more that the best studies are showing it's not just a medical response to mental health illness that is effective, but when we couple it with a really good counseling treatment plan. And it allows that to happen much better. And again, because the patient is already in a familiar place, the counseling piece follows more easily. Another thing I would add just to that is I think that this is also a stepping stone in challenging the moral injury that we're seeing in so much of the medical field as well as other provider fields, because it's not now patients are only coming to the medical world for mental health treatment, but they're able to have access to the actual treatment that will be helpful for them, and it relieves some of the burden for our staff. And we've, I think our staff would say, like our other medical providers would say, that it feels very supportive to be able to say, okay, this patient is doing this, this, and this. What would you suggest until we get them in? Or those kinds of pieces. Another great advantage is because we are outside, we are able to minimize the overuse of diagnoses. In the third-party payer system, much like the medical third-party payer system, to treat a patient, a therapist has to diagnose. And without a diagnosis, the therapist can't continue to see a client. So there's some ways to navigate this. And I talk to colleagues who do this. But of course, the cost is primarily on the therapists to ethically weigh treatment with accurate diagnoses. We've come up with some great ones to help bridge some of the gap. We have one called adjustment disorder, which just means you don't fit yet, but we still want to be able to treat you. But this is a game, and this is also borders on how much are we helping an individual by having to label with a diagnosis. I could talk about diagnosis and some of my ethical challenges with it for far more than we have time today to do. But when we aren't having to bill to see someone, I don't care about diagnosis at all. If you're in my office and you're ready to do work, that is what matters. And it doesn't matter if you actually meet diagnostic criteria, and we don't have to fudge some things or some symptoms or gray some of the edges, maybe is a better word, so that I can keep seeing you. Patients then see therapists more often because they don't have to meet criteria, and they can stay in the therapy process even when they are getting better. Because if the diagnosis starts to go away, then we have to think of something else to be able to treat you. So huge asset, especially to the therapists on the provider end, to be able to treat, but also we're not putting labels and pathologizing life and human experience, which is a lot of, I think, what happens in the third-party payer system when diagnoses are overused. We're seeing also a big shift, or not maybe a shift, but an inclusion of mental health, people who seek services in our counseling or in our clinic for mental health and not just for mental illness. When it is accessible to them, individuals have shown that they're actually really interested in being better of themselves, to actually work on things that aren't they're not necessarily crazy by any means, and they get to just be better versions of themselves. Or they work on things that they hadn't thought about before, like their relationships or how they communicate. And this has been a really exciting thing, I think, especially for our therapy team, as well as the medical team, that people want to not just get over an illness, but they want to stay mentally healthy. And we're able to talk about things like emotional intelligence and developing healthier coping strategies and developing self-understanding, lots of really fun things that translate to people being healthier out in the world as well. Some of the unexpected things that we have run into is that the demand has been a lot higher than we thought. We assumed at first we would rely heavily on the referral system from the PCPs because that's what happens out in the other world in the system, and we haven't. So often I'll say, "Oh, I'm seeing this patient," and the PCP is going, "Oh, I didn't know that. I didn't refer them," and so that's been really fun. Again, it's because of access, and people get in even without knowing they don't have to go through the PCP for a referral. It's also been, we have a lot of people sign up because we have mental health services, and they don't necessarily even care originally about the medical side of our membership. They eventually latch onto it usually too, but they come in because we are available and because it's far more affordable than even using their insurance if they had coverage. It also allows us to see a lot more couples for relational type things that are in the system more difficult to find services because it's more difficult to get to bill for those. Another piece that was unexpected is we've found a large interest in having workshops and seminars. For me as a therapist, that was pleasantly surprising, but no one wants to do group. You say you're doing group counseling. No, I don't want to do group counseling. But if you call it a workshop, they show up actually in large quantities, pack 35 anxious people to talk about anxiety in a room. And if you call it a workshop, they're there. So that's been really fun to be able to emphasize more of a psychoeducational piece, and more people being able to get access to the mental health services here, even like via Zoom. Once COVID hit, we went to Zoom. It had so many seminars about, what are we doing? How do you navigate this emotionally? And I think a lot of people were able to tune into that they wouldn't necessarily, obviously wouldn't have come in, especially at that time because no one was going anywhere. But we're able to get some of those immediate mental health concerns addressed through that kind of a platform. Another piece that we were surprised about is we had integrated at first, this is kind of linked to the first one, but we had integrated what we called soft handoff. So because we thought we were going to utilize referral process far more, it's actually a wonderful system. Is the individuals would come in, they would see one of their primary care providers, and the primary care would say, okay, I think you should do some counseling. Let me go introduce you to the therapist. And they would come grab the therapist, and we would come and spend 5, 10 minutes at most just meeting them. And it was the psychological reassurance of passing off, like handing them off, because they already trust their PCP. And now, okay, I can again vicariously trust this new person. And then that therapy relationship already has started to develop. So when the patient now comes back next week, when we schedule, you've already had a face to who you're going to see. That's become familiar to you. It's really like you hit the ground running. It's a great system. It is time consuming, and we've just become too busy. Our therapists are all in sessions all day to be able to utilize that. I think once in a while it still happens just by kind of coincidence. But it's also, we've noticed we didn't need it as much because people were even just doing self-referral. So that was unexpected. And the last one that I think is really important is time is not therapy. I definitely would say, like, as the therapist, I kind of came in knowing this, but it's been a learning curve for the medical side, because there's so much expectation that medical providers spend all this time with their patients. And I think this is another piece of, especially maybe in DPC, it's the thought that if I spend more time, we're going to get more done. And time isn't in and of itself therapy. And I don't have time to, explain some of that, but we had some really good and bad demonstrations of mistaking that, where pop therapy, pop psych is being done in the medical office, and now the therapists are basically undoing the knot that was accidentally created. So I would really encourage you, if you're considering that, to not get caught in that trap of, if I just spend more time, I can do some of the mental health coaching or life coaching or therapy that I wish I could do, because the training just isn't there. And there's a lot that actually goes into the hours that the therapist spends with the client.
Yeah, I could think of a couple examples where, I'm not trained in therapy. Maybe I missed that day of medical school, but anyway, I can help the patient. I can hold their hand. I can listen. I can pray with them when that's appropriate, but that's not real therapy. We had one patient, just again quickly, where she always had her broken down mother in her home. And I would listen to her cry about this every time she came in. And eventually her mother died. And then within just a short period of time, she actually moved her broken mother-in-law into her home. And that just really surprised me. And of course, Holly looks at me like, well, of course. She has a personality disorder. She needs that. And if her mother-in-law dies, she's going to move a handicapped person in or something. She has a need to be needed or something, which totally went over my head. Because again, I'm not trained in the counseling. I just don't know what that's all about.
Those things in and of themselves aren't a personality disorder, but the client did have a personality disorder. So the last piece, really quickly, this is what we've implemented, is our counseling program includes 2 pre-counseling workshops that they now do via Zoom. So those are 50 minutes, which are very purposely designed so that they, again, they start to get used to this. I'm going to come this week for 50 minutes, and then I'm going to come next week at the same time for 50 minutes, and they start this process. They then receive 12 50-minute counseling sessions, which includes an intake. And then they get, in any additional sessions, they can continue for $30 fee, which we have lots of people do that. And then we do also, and with membership, you can attend any of the topical seminars or workshops that we've done along the way.
Great. Yeah, this is fun. So a lot of the questions that have come in have been around, okay, what do we do? Is this actually included in our DPC model? And so I'm going to address a couple things now. One, like this is how our counseling program works. It's everybody. We don't have a tiered rate. Everybody that joins Assurance Healthcare and Counseling Center, our DPC clinic, has the option to choose mental health, to have mental health if they want it. It's included in their membership. We don't do any tiers. We believe in it so much that from the very beginning, Holly joining us as a partner, and then us just saying we're going to invest in mental health with our patients and with our practice, and this is going to be the model moving forward. We've done everything around that. So with as far as how we pay our mental health counselors too, that's another thing that Dr. Edgerly, like props to you for being the one that has really started this and said, you know what, I believe in this so much, I'm going to pay my mental health counselors salary. And of course, Holly's a partner, so she invested in the company as well. But it's an investment that we have made and have said, okay, we're going to take salary cuts because we believe in this so much for our patients, and it's worked well. So that's how we've incorporated just the paying of our counselors into the program. Some other questions are, what about pitching to employers? So there's one question that said, when you pitch to employers, this seems like a huge value add. Do we have data on the reductions of costs? So that's two parts. Absolutely, yes. It's a huge, I'm the one that gets to talk to a lot of employers quite a bit. And it's a huge benefit, a huge value add to just say that we have counseling available. Even I was on a call the other day with an employer. The fact that I said we could do workshops, a lot of these workshops, especially in the midst of COVID and do an anxiety workshop, just the fact that we had that in access was huge to this employer. As far as do we have any data on reduction of costs? No. We don't. We don't keep track of that data, and quite honestly, it's more about patient satisfaction and true healthcare than it is cost, really. And it's probably hard to measure, I would say, as well, because the utilization of true therapy is so low, because the accessibility to it is so extremely low, that it's hard. It's going to be hard to define that cost savings. So
I think also I would say, Jason, that so much of that, as far as business, why I think it's such a selling point for businesses is because right now it's sourced to the HR who are saying like, we don't have the capacity to do this. And so the idea that real services get to be provided for their staff, I think is a real big selling point.
Exactly. A lot of the big programs will have their EAPs, their employee assistant programs. And a lot of times, they're between 3 and 6 sessions,
usually,
which is, not as many sessions as a lot of people could actually use to actually, better themselves. Let's see. Can you speak a little bit to the how we're able to be creative in our care to patients? I think you spoke about that a little bit, but that was another question. I'm going to keep scanning the
creative.
The
like, how do we
just versus the typical typical therapy is one-on-one 50-minute sessions. We also do workshops. Like, how else can how do we incorporate you as a mental health counselor into our practice? What's the benefit of having you every day in our practice, whether it's alongside patients or even alongside providers?
I think I'm understanding of just beyond the benefits that we already talked about. Are you thinking of something, Jason? You can go.
Well, mostly just everything that you talked about, seminars, workshops, high access to people, even your daily collaboration with, and even behind the scenes collaboration with maybe somebody you have not seen in therapy, but you're able to walk through a PCP, one of our other providers, and help them through other patients, through some of their patients.
I think that it's, when you get out of the billing system, you don't answer to a billing system. I'm even right now, I am training an intern, or I am training an associate licensed therapist. So she doesn't have her own full license yet, who's been in the system. And so much of our consult is, well, that doesn't matter. Remember, that's a billing issue, actually. That's not a treatment issue of, well, we didn't get this done, or we didn't answer this question, or, well, the patient did this for a long time. It's you can sit in silence maybe for a whole half a session, just being with someone depressed and not have to worry about how am I going to write this note because sometimes just sitting with someone is therapy. That's it. Or we're able to say, okay, we're going to join these two. This is a real example. These two sisters right now are fighting, and they are both in individual therapy, and they're youngish. And I said, let's put them together and let's just do couples. Basically, let's do sibling therapy with two of them. When you don't have to bill, when you don't have to think of how are we going to bill this, you just get to help actually what the need is at the time. And so those are other creative ways that that we're navigating all the time, I would say.
Yeah. Yeah. So much faster. Holly, talk about your training. So one of the questions was, it seems like you somebody's been learning about CBT and ACT. If somebody's looking to either hire a therapist or, even refer, talk about your training and kind of the kind of therapy that you do and that just we have looked for.
I was a psychology undergrad. I majored in psychology, and then I went to a strong CBT master's program, and then my internship was strong ACT, so ACT therapy. So I have those two strong emphasis. And then since then, I basically seek out predominantly like more psychodynamic or the psychotherapy realm. That's beyond the scope of today. But I would say if you're looking for someone looking in the CBT or the ACT, anyone and person focused, the reality is, here's the other reality, is there are wonderful therapists and they might not say, I practice CBT. At the same time, everyone's been trained to say we practice CBT because it's evidence-based, because you have to practice evidence-based to be able to bill. And there's a lot of wonderful therapists who one have said, we're just going to go be cash pay so that we can do it the way we see that is best. And they're not using therapies necessarily that are harmful to patients at all. In fact, they're helpful, but they're not, quote, evidence-based. So I would say use that with some good discretion. The biggest difference between behavioral health, if you're looking at someone who says, I'm a behaviorist, that is really focused almost exclusively on wanted or unwanted external behaviors and how to either increase them if we want them or to decrease them if we don't. And so there's a time and a place for that, absolutely, but it is a far more surface level, and you don't get the other buy-ins, again, of like people wanting to do psychoeducation or better wellness, or I want to improve myself. Those pieces would be easier. Again, they're easier to implement, but they're not necessarily going to give you outcomes like we've been talking about today.
Have we talked a little bit about what pre-counseling workshop entails usually?
Yeah, so the pre-counseling workshop we call Preface, and I took some of it from what my internship used to do that I found was really helpful. And so individuals attend 2 50-minute sessions now via Zoom, and it's very psychoeducational. It's a real, here's some tools you can start using right away. Here's some conceptualization of what therapy looks like. Here's some normalization of what happens in our lives and how do we deal with them. We have to start developing coping strategies. I talk about the emotional spectrum that is very much minimized or misunderstood, I would say, culturally, that we have to have as humans, we want a whole spectrum of emotions. How do we respond when we have uncomfortable emotions? So it's really just very introductory, some basic things, but also teaching people how to journal. How do they start doing some tools on their own as before they start the therapy process? And we have some clients that go through that and say, okay, that was actually really good. This is helpful. I'm going to run with this. And then we have other clients who then, move right into individual or couples therapy after that, or family therapy.
Thank you.